So we can get started. Thank you. Welcome everyone to December Visiting Professor. Happy holidays to everyone. I don't know how many of you had the opportunity to go to the consultants course that was last weekend. Around 2,000 cardiologists from around the country got a taste of what we do on a regular basis here. Really looking at cutting-edge information in cardiology by experts, and we're very privileged to have a panel of experts today. Today's visiting professor, Dr. Iannuzo, will be introduced by Dr. Fuster more formally in just a few minutes. I just wanted to tell everyone about some changes in the schedule. Dr. Gottlieb, we were privileged to have as one of our visiting professors this year. He's the current commissioner of the FDA. Because of conflicts, he's going to come in March instead of January. And Marty Marin from Tufts, who's he and his father are the world's experts on hypertrophic cardiomyopathy, will be coming in January. So that's just the change in the conference. I have outside is a questionnaire for people to fill out about prospective visiting professors for next year. Please, now we're starting to send out invitations for the next calendar year for those people who think would qualify as our expert today, internationally renowned, clinically savvy. Those are the type of people that we want to stimulate our fellows. So without further ado, this is a difficult topic to put together. Dan did an excellent job. Dan?
Thank you, Dr. Goldman. Heart failure is a heterogeneous collection of syndromes that result in the inability of cardiac function to adequately match the demands of the body. This deficiency can present with the inability to exert oneself and can progress to the failure of the heart to sufficiently perfuse vital organs, resulting in fatal illness. As newer devices and therapies offer abilities to interrupt and reverse the trajectory of disease, the identification and classification of heart failure has growing importance. Accordingly, the understanding of the pathophysiology of heart disease has reached new value in the therapy of heart failure. As an example, implantation of an internal defibrillator may now be considered based on fibrosis found in MRI. While this understanding allows improved targeting of our therapies, it highlights the complexities involved in the treatment of each patient. While advanced cardiac imaging provides new insight into the specifics of disease, it requires special planning and involves significant costs, limiting its utility at the bedside. While physical exam remains the cornerstone in the diagnosis of heart failure and daily management of the patient, biomarkers may offer important adjunctive knowledge to the magnitude and drivers of disease and help tailor therapies towards those that may derive the most benefits. My hope over the next few minutes is to define the current use of biomarkers in clinical practice and describe new roles that biomarkers may soon play in the management of patients with heart failure. One cannot discuss biomarkers in heart failure without starting with BNP, or B-type natriuretic peptide. BNP is a neurohormone that is secreted by the heart in response to ventricular stretch. Its construction requires the cleavage of a precursor molecule into BNP and a byproduct known as NT, or amino-terminal pro-BNP. NT-proBNP has no known biological activity. It has a longer half-life than BNP, resulting in higher levels in the blood, and is not cleaved by neprilysin. This is especially important in the area of neprilysin inhibitors, such as Acute. The most established role of BNP is in the identification of the patient presenting with heart failure symptoms. In the aptly named Breathing Not Properly trial, BNP was compared to clinical risk scores in the diagnosis of patients who presented with dyspnea. BNP alone proved more accurate in identifying those with heart failure than either of the clinical risk scores it was compared against. A very similar trial, the PRIDE trial, was conducted with NT-proBNP and demonstrated similar results. Since then, these biomarkers have frequently been used in the emergency room to help diagnose and guide management of complex patients presenting with dyspnea. While there are no replacement for clinical skills, they offer valuable adjunctive information to confirm a diagnosis of volume overload and expedite management. While this role of BNP has been clearly established in the diagnosis of heart failure, I hope to spend the remainder of the talk describing the prognostic roles of cardiac biomarkers and the potential to identify patients who may benefit from more intensive therapy. In acute decompensated heart failure, the ADHERE registry showed us that patients presenting with volume overload and either preserved or reduced EF had a risk of death that increased along with BNP levels. Furthermore, BNP levels appear to be modifiable in line with therapies that have been shown to benefit patients with heart failure. In various studies observing patients receiving neurohormonal antagonists or non-pharmacological therapies such as cardiac resynchronization, BNP levels have been shown to decrease over the weeks to months after the initiation of therapy. Resultantly, the concept of a BNP-guided approach to guide therapy has been a target of recent studies. The GUIDED trial is the largest study to date, which compared NT-proBNP levels guided management to standard of care in the management of the chronic heart failure patient. This study was stopped early as there were no differences in neurohormone levels or outcomes across the two groups. While there are many criticisms of this trial, it leaves us with the need to find novel biomarkers which may offer additional insight to the management of our patients. We start with Audrina Module. Audrina Module is a neurohormone not dissimilar from BNP. It is measured as a precursor protein known as MR-ProADM. Like BNP, its release has been found to correlate with stretch in vascular smooth muscle cells and cardiomyocytes, and its levels increase in the setting of heart failure. Also like BNP, it has a physiological role in vasodilatation and diuresis. In the BOG trial, it was compared against BNP in terms of diagnosis of heart failure in patients with dyspnea and proved non-inferior. In terms of the prognostic yield, Audrina Module levels were found to be independent and additive to BNP levels and the risk of death in patients with acute and chronic heart failure. A better-known neuropeptide, vasopressin, has also been shown to be elevated in heart failure. The mechanism behind its release in heart failure is not entirely clear. Unlike BNP and Audrina Module, it serves to retain fluid and vasoconstrict, making its role in heart failure pathological rather than counter-regulatory. As vasopressin is released in a pulsatile manner and has a very short half-life, a more stable byproduct of its creation known as copeptin is used as a surrogate of its release. Copeptin levels have not been shown to be useful in the initial diagnosis of heart failure. Rather, its use is predominantly in prognostication. Elevated levels of this protein portend an increased risk of mortality independent of BNP levels, as well as independent of serum sodium. Another well-recognized cardiac biomarker that we all know is cardiac troponin. While typically thought of as a marker of acute coronary syndrome, high-sensitivity troponins also play a role in the stratification of patients with heart failure. Release of troponin may occur from oxygen supply-demand mismatch, resulting in diffuse ischemia, or myocardial apoptosis, resulting from the inflammatory state of heart failure. Even so, some studies have found that its release may take place from viable myocardial cells as a result of stretch. Regardless, similar to prior biomarkers, its elevated levels portend a worse prognosis in the heart failure patient. Inflammation and fibrosis are the pathological factors that drive the progression of heart failure. As a result, markers of this pathology have been studied as prognostic indicators in heart failure. CRP, for example, a marker we all know, is nonspecific but easily testable marker of general inflammation. It is released by the liver as part of the acute phase reactants. Because CRP can be elevated in a myriad of different disease states, it has little value in the diagnosis or classification of heart failure. However, an increase in CRP levels have been shown to be a negative prognostic indicator. ST2 is a less known biomarker and acts as a cytokine receptor for interleukin-33. It exists as a membrane and as a soluble form. Binding of IL-33 to the membrane-bound receptor results in a protective effect against hypertrophy and cardiac fibrosis. However, binding of IL-33 to the soluble form has no cardioprotective effects and decreases serum levels of IL-33. This, again, suggests a potential pathological role. The mechanism of soluble ST2 release may also come from myocardial or vascular endothelial cells as a result of increased pressures. Elevated levels of soluble ST2 have been shown to correlate with worsened outcomes, including increased mortality in patients presenting in the emergency room with dyspnea. Galectin-3 is a lectin or carbohydrate-binding protein found in various cell types, including fibroblasts. Activation of galectin-3 has been shown to stimulate fibroblasts to synthesize extracellular proteins such as collagen, leading to fibrosis and adverse cardiac remodeling. Its levels have also been seen to correlate with heart failure severity and give valuable insight into the prognosis of the patient. GDF15, or growth differentiation factor 15, is a cytokine member of the TGF-beta family. Its expression is increased in the setting of volume overload or myocardial ischemia and is thought to be a signal of inflammatory stress. It has demonstrated the ability to prevent myocyte hypertrophy and apoptosis in animal models. It has been shown to actually have improved prognostic value to BNP and to be particularly useful in patients with preserved ejection fraction. Finally, matrix metalloproteinases, or MMPs, are enzymes that act on extracellular matrix proteins as well as a number of other substrates that participate in inflammation. Because of their role in tissue remodeling, MMPs, particularly MMP9, are an important component of the pathophysiology of cardiac remodeling. Tissue inhibitors of metalloproteinases, TIMPs, are extracellular proteins that bind and inactivate MMPs. TMP1 has been shown to be particularly important in the activation of MMP9. As such, it has been shown that it has been found that an imbalance between MMP9 and TMP1 may be a signal of increased remodeling and thus worse prognosis in patients with heart failure. As demonstrated above, these biomarkers may aid in the diagnosis and prognosis of heart failure. They have been shown to add information independent of that gathered in current routine clinical practice and can contribute to independent of each other in the ability to identify the at-risk patient. This may have an important impact in trials to homogenize the patient population and ensure the proper diagnosis of heart failure. Furthermore, their use as potential therapeutic targets have clearly been outlined in the advent of therapies such as Entresto. The use of BNP has become widespread frequently in emergency room settings where it has been proven to help identify patients whose symptoms are related to volume overload. While BNP levels have clear prognostic implications, whether that adds to the clinical assessment of the outpatient remains unclear. Biomarkers other than BNP, such as ST2 or galactin-3, may give more insight into the pathophysiology of a patient's disease and demonstrate benefit in guiding targeted therapy. Finally, it has been demonstrated that pooling biomarkers improves their prognostic value and suggests that such an approach would improve their ability to identify those who require more intensive therapies. Regardless of the model of the marker used, it remains to be seen whether biomarkers can have a major impact in patient outcomes with diagnosed heart failure. Thanks.
Thank you very much, Dan. Good job on a very interesting subject. And we have really today the great fortune of somebody who has contributed so much to it, which is the field of biomarkers. We have Dr. James Iannuzo with us today from the Mass General. And I'd like to say a few words about him. First of all, he was born in the neighborhood, Flowers Hospital, you know where it is, Fifth Avenue, just 4 blocks from here. So he's really a New Yorker. He looks like a New Yorker, by the way. When you talk to him and you deal with him, you were born here. MD at the New York Medical College, Valhalla. Then he had his internship in residency at the Brigham in Boston. And then he had his training in clinical cardiology and clinical research, actually, at the Mass General. Then he moved, he got into the Mass General as a staff member, and he moved from assistant professor to, in 2015, as the Roman DeSantis Endowed Distinguished Clinical Scholar in Medicine, and then subsequently as a Hatter Family Professor of Medicine at Harvard Medical School in 2013. So his CV is quite impressive, actually. He became at the Mass General Medical Director of the Cardiovascular Executive Health Program and then Medical Director of Cardiac Intensive Care Unit. And then he moved nationally and internationally, and he has been a tremendous asset in the cardiovascular field. So he chaired important committees like the international committees in pro-BNP, International Committee on the Definition of Myocardial Infarction, on also recently in the sensitive troponin consensus panel, the task force of experts consensus documents and health policy statements and so forth. I think the most interesting part of Dr. Iannuzo is quality and quantity, I have to tell you. First of all, if we go into clinical trials and guidelines, he has been in the monitoring committees or chairs in 30 of such clinical trials and guidelines. I had to count just to give you the accurate number, just 30. He's in the editorial board of actually 14 journals. He's associate editor of JACC, and he's associate editor of JACC Heart Failure. Then you go into his awards, and he has 25 measure awards that go from medical school to Valhalla to Brigham and so forth, and then a number of national and international awards. Then you go into his projects, his funded projects. I just give you the number, 30. And then, so I did a lot of work today to really count everything you're doing. And then you say trainees. He really trained very specifically as a mentor. I counted 30 trainees, which is a significant accomplishment. and supervising him. And then he has been very, very involved, of course, with teaching at the medical school at Harvard and many, many other places in the world. Now, his bibliography obviously is very rich, for about 400 papers. And really, you know, cardiac failure has so many facets. When you look at his CV, he has been working in so many things in the cardiovascular field, and certainly he's very well recognized by the topic that will be discussed tonight, which is the issue of biomarkers. I'd just like to finish by saying he's a unique person, he's a great human being. I deal with him every week with the editorial board of JACC. He's a tremendous judgment, and frankly, we feel very proud you visited us today, James. And I'm going to give you just something to remember. Another of the plaques that you already have, I am sure, and it's the faculty and fellows. We express appreciation to you for outstanding teaching, wisdom, and expertise as the Anandi Sharma Visiting Professor and the Simon Dag Memorial Lecturer today, December 18 of 2017. Congratulations, and again, it's a pleasure to have you here. This is a check, not too much, but it's there. All right?
Thank you very much.
Thank you. It's a pleasure.
Yeah.
Okay, good. Sure. What we are going to do is to, you take a picture?
I'll take the pen.
With,
Yeah.
just stand here.
Just have to be in the light, otherwise everyone's in the shadow.
Clear? All right, thank you. So you can sit in the middle over there.
Thank you.
And I'm going to call the other panelist. Dr. Donna Mancini is going to be the moderator. Annie, you're here. Lala, you're here. Gina La Rocca here. Sempini, and certainly Dan. So I hope you have a good panel. Donna, this is a very tough subject. I'd like to see how you manage.
Okay, all right. All right. Thank you for all agreeing to participate in the panel. And thank you, Dr. Iannuzo, for being our resident expert. And you're very welcome to Mount Sinai and New York City and the home of the Yankees, despite the fact that you're a Red Sox doctor.
Yes, she had to mention this, but the one thing that Dr. Fuster didn't mention is that since 2005, I've been one of the team physicians for the Red Sox. So it's, yeah, well, you know, it's an interesting thing. It creates a lot of interesting discussions at holiday dinners with my family.
So, but this is a Yankee hospital. Okay. Okay. So let's start with what exactly is a biomarker? Sean, what's a biomarker?
So a biomarker, just very generally, is any test, usually a blood test, that provides some insight into a patient's prognosis or condition.
So is a biomarker anything that we can measure?
Is it anything we can measure? Yes, it's something that we can measure, and we can talk about a biomarker versus an ideal biomarker, but an ideal biomarker would be something that reflects either a physiologic state or a pathophysiologic state. It should be able to be quantified. It should be reproducible. Mm-hmm. It should have a correlation between what you're measuring and what it's reflective of. So yes, one of the criteria would be something that we can measure.
So when Dr. Iannuzo gave his lecture this afternoon at noon, he referred to heart rate as a biomarker. Would you consider heart rate a biomarker?
What I consider a biomarker, it is a physiologic sign, and it is a marker of heart rate, and therefore it is a biomarker. Mm-hmm. But I think in the traditional sense of what we think of as a biomarker, I still think of it as usually a serologic test.
Yeah. You know, Dr. Iannuzo?
Yeah, so in the lab medicine world, we say that a biomarker is anything that costs more than $15, and if it's less than that, it's a blood test. But, all joking aside, to some extent, I think it's important to recognize that there are some things that can be considered in the same roles as, say, some of these more esoteric tests that Dan mentioned that provide quite comparable information. It would be irresponsible in the biomarker research world to deny the fact, for example, that heart rate, as an example, just as the version that Dr. Mancini gave, a single measurement is prognostic, higher is worse, lower is better. Serial changes are prognostic, and therapy to lower heart rate may improve outcomes. So to some extent, it meets many of the criteria that we ask of the blood tests that we use. But I would say that as a biological measure, it's hardly specific for a pathophysiology per se. So it meets some of those criteria, but is a little bit different on a scientific level than say, measuring a marker of T helper cell 2 tolerance like ST2.
But, the definition, the point is that the definition for a biomarker is very broad. Serum sodium, creatinine, they're all biomarkers. What about microRNAs? Are they biomarkers?
So for the audience, microRNAs are ubiquitous, short, typically fragments of RNA that have most often more than one role in vivo. Back in the dark ages when I worked in the lab, RNA was something to be feared because it was vulnerable to easy degradation. And shockingly enough, it turns out that microRNAs are in fact quite stable and play a role in terms of a number of different processes, including regulation of other RNA and other genomic processes. Therefore, their measurement, in theory, can infer not just presence of disease, but disease activity. And indeed, there are examples where microRNAs may be useful for identifying heart failure, just as accurately as BNP. As well as disease activity and modulation. The problem with microRNA is that, number one, they're difficult to measure still. There's no rapid platform for their measurement, and they're very expensive. So it's not something that is ready for prime time by any stretch.
And what about cell-free DNA?
Don't know much about cell-free DNA other than to say that it is possible to extract it from samples that we previously have saved, and we have done some genomic work. I don't see much of a role on a clinical level, but certainly for genomic or genetic analyses, possible.
Okay. So biomarkers have a role in predicting prognosis, in making diagnosis, in assessing the response to treatment, and as a guide for treatment. There's lots of biomarkers, and they fit in different categories. And as the expert in this field, which biomarker would you say would be the best to quantify myocardial stress?
I'm curious to hear what everyone else thinks. Certainly the experience with the natriuretic peptides is greatest. I think that there is reason to have interest in a marker that Dan did not mention, but sort of tangentially related to natriuretic peptide metabolism. It turns out if you measure, in your institution you measure BNP. If you measure BNP with the assay in your lab, in a patient, for example, that Dr. Penny takes care of, somebody with advanced heart failure, the BNP that you're measuring, put it in quotes, it's not actually, the majority of it is actually not BNP. It turns out as heart failure advances, the cardiomyocytes release increasing amounts of an uncleaved precursor version of BNP. So BNP and NT-proBNP come from a precursor peptide that in health gets cleaved into the two peptides. As we get sicker in heart failure and wall stress rises, for reasons that no one quite understands, the ability of the cardiomyocyte to process that precursor into active BNP and inactive NT-proBNP is lost. so that what's being released is largely that inactive precursor peptide. The problem is the commercial assays for both NT-proBNP and BNP can't tell the difference between free and uncleaved peptide. And so one of the things that is of great interest is trying to understand why the cardiomyocyte shifts over to releasing this uncleaved precursor. And the reason why this is important is because it doesn't exert any of the vasodilatory benefits of BNP. And so as you see more and more of the so-called proBNP 108 released, it identifies a patient at great risk. And so we're doing work now trying to understand how patients shift from the active BNP phenotype to the inactive uncleaved phenotype. Understanding that could theoretically inform new pathways for drug development to try to enhance activation. And so we're measuring the uncleaved precursor in terms of its ratio to free and uncleaved in, for example, patients treated with sacubitril valsartan and other novel heart failure therapies to try to get a sense if some of the benefit is shifting from the inactive to the active phenotype.
The next area is myocardial injury. And what will you consider now to be the best biomarker for myocardial injury? Is it high sensitivity troponin? And since you are on the guidelines panel and you're going to write a statement, I think we should take the opportunity of having you here to really educate us as to the value of this biomarker and how we should use it.
So there are basically two cardiac-specific markers that we use currently in clinical practice and even in research, to be honest, and those are the natriuretic peptides and troponins. And therefore, by definition, they are of great value given the sense that they are largely, although not exclusively, released by the heart. The natriuretic peptides are found in small quantities in other organs, troponins as well, especially troponin T. We have a paper coming in JACC looking at expression of troponin T in skeletal muscle after significant injury to the muscle has occurred, so like patients with chronic myositis. They get upregulation of the fetal gene program and they get expression of troponin T, the cardiac isoform. So I'll answer the question in brief form about highly sensitive troponin, and then I'm curious to sort of hear the perspectives from different points of view, population science, heart failure, and others. So the highly sensitive troponins, how many, you guys have heard of the fact that they're coming? Do you know that we're all going to be using them probably within the next year? Certainly, depending on your clinical labs, if you are a hospital that uses troponin T, which we are at Mass General, the assays are already available. We just haven't converted. It's like opening Pandora's box to some extent, going live with a new test before we really have our SOPs in place. So the difference between highly sensitive troponin and conventional troponin is sort of like the difference between a regular confocal microscope and an electron microscope, right? The difference is not the assay itself or the analyte. It's not that there's any difference between the troponin that you measure with one assay and the other. The difference is how you measure it. So with the highly sensitive assays, what the difference in the assays is that the antibodies that are used to bind troponin are more heavily labeled. Therefore, they send off a lot more signal that can be detected. In addition, the test is a little bit longer and you use a lot more sample in order to be able to detect even minute quantities of troponin. The advantage of the highly sensitive troponins is that you can detect a number in most people. So if I measured a regular troponin in everyone here in the room, most of us would be less than assay, right? It should be that way. With the highly sensitive troponins, everyone has a number. So the concept of being troponin positive and troponin negative, that's got to go away. You need to move away from that concept because everyone's going to be technically troponin positive in the sense that everyone will have a number. The real question is how high is the number and why? In addition, the advantage of the highly sensitive troponins is that they are able to resolve small differences with high resolution. This allows us to test them at much more rapid intervals when we're evaluating for myocardial infarction. So the standard is every 6 hours times 2 for conventional troponins. With highly sensitive troponins, you can rule somebody out with 2 measurements an hour apart, 0, 1 hour, done, or 0, 2 hours, done. So there are advantages. The disadvantage is that everyone has a number. And in fact, the sicker we get from non-cardiovascular disease, the more likely we are to have a measurably elevated value that's above the reference limit. And so that may cause more, quote, false positives. Now, I caution you all to remember that when a troponin is elevated, it's not falsely elevated because of an analytical mistake. It's elevated on a biological level, but it may not be an acute myocardial infarction. So before I shift to other specialists to get their view of the highly sensitive troponins, the simple take-home is, with the highly sensitive troponins, a single measurement is not sufficient to make the diagnosis of a myocardial infarction. You need to see a rapid delta, a rapid rise that's substantial before you can make that diagnosis. On the other hand, a measurably elevated but unchanging value is not an MI, but very prognostically important. It identifies a patient at significant risk for cardiovascular complications. So I'm curious, in population studies, we found in the Framingham, for example, that troponins were as good as the natriuretic peptides for prognosticating new heart failure in patients without. Have you seen anything like that in your analyses?
So based on our research at the NIH, we looked at the matrix metalloproteinases and their inhibitors, the tissue inhibitor metalloproteinases, and compared those to well-established biomarkers from Paul Whitaker from Boston, the high sensitivity C-reactive protein, and a very standardized biomarker, EGFR. And what we had seen by just looking across the board in this AGES Reykjavik study of nearly 6,000 individuals was that TIMP, the inhibitor of matrix metalloproteinase 9, was significantly elevated, and it was associated with all-cause mortality, cardiovascular death, second only to age in this larger aging population in Reykjavik, and a third indication for cancer death in the same population. And it far surpassed HSCRP, which is exactly what the CANTOS study was published at the same time, and I guess they didn't want to really hear that, but I guess the point is that there are so many biomarkers out there, especially in these population-based studies, and now the question is, now that we have them elevated, that we know how do we target them and what do we do? We've made a diagnosis, we might even use them for prognosis, but how do we target them for treatment?
Well, let me turn that back to you and ask. I mean, what do you think is the prerequisite? What are the prerequisites for knowing how to manage an elevated value of TIMP1, for example? From an investigational perspective, what would your strategy be to figure that one out?
Yeah, that's very interesting. That was one of the weaknesses or limitations of the study. It was a measurement in one point in time, and if you look at all the publications that have been published, especially going back to 2008 with Eugene Braunwald in the New England Journal of Medicine, he did a beautiful review of biomarkers in heart failure, and he really broke it down, and he said, we could take a biomarker and look at diagnoses, or we could take a biomarker and look at prognoses. And if we look at diagnoses just initially, the biomarker has to be elevated and sustained. The test needs to be reproducible, just what Dr. Pinney was mentioning earlier. It has to be cost effective. It has to be widely acceptable and used in a hospital. And you have to use this biomarker across a general population. It can't just be for a pinpoint population. It has to be generalized to a large group of patients. So those are the limitations of a biomarker, but it's also a guideline that we should use, because a lot of publications could come out on biomarkers, and then we don't know what to do with it. So there should be some strict standardizations when looking at biomarkers in the population basis.
One area that I wanted us to discuss was the use of biomarkers in the diagnosis and management of acute heart failure, because I really think that that is the most impactful that the biomarkers have hat on our practice. And Anu, when you were at the American Heart Association, you gave such a beautiful presentation on congestion and heart failure. And I want you to say how you use biomarkers in the setting of acute heart failure.
First of all, thank you. I want to be a little bit maybe controversial in saying that I don't really use biomarkers that much in the setting of acute heart failure, namely because I think that it has to be taken into account in the clinical context of how a patient presents. And I think because we're so eager, and essentially what the talk had alluded to is that we don't have a very good handle on what congestion is and what the definitive representation of congestion is. Is it a biomarker? Is it the combination of physical exam findings? Is it just the patient's symptoms? Put simply, it's essentially an elevation in cardiac filling pressures that then is, sort of called or coined as hemodynamic congestion that then, once it leads to symptoms, is then called clinical congestion. And I think oftentimes where, the natriuretic peptides have gotten a lot of play is when someone presents with dyspnea, which is the most common complaint in acute heart failure. The question with someone, especially with pre-existing pulmonary disease, is it the heart failure that's leading to their dyspnea, or is it their pulmonary disease? And how can we best differentiate those two etiologies?
I'm calling for patient Jose West.
I'm sorry about that.
And I think that's where many clinicians, especially in the emergency room, have looked to natriuretic peptides to be able to differentiate those two patients. And I think one thing that may get lost in that popularization of natriuretic peptides is the fact that we don't look at the entire picture. And so I think that number that we get often has to be taken into account of the type of patient we're measuring it in. So we know that age, and we know that body mass index, and we know that renal function all influence how high or low those levels are. So we can't use that as the one deciding factor. For that reason, it's not something that I look to unless I'm confused.
But Anu.
Yes, go.
Don't you think that most of the studies that have shown the efficacy of BMP have been the value of it in identifying patients in the ER who actually have heart failure? And don't you think that those biomarkers may actually play an important role in helping us to stratify patients who are coming into the hospital? And maybe even identify people that we can send home from the hospital?
Not really.
No, really? Why?
I think it's been taken slightly out of context. I think we need to do a better job of putting all these different pieces of information together to decide whether a patient is in acute heart failure or not, and then appropriately whether they can be treated with diuretics and sent home, or sent home with follow-up, et cetera. I don't think that is the one sort of test that we can hang our hat on to differentiate patients.
So if someone comes to the ER and has a BMP of 4,000, you're going to disregard that?
I'm not going to disregard it, but I'm going to ask for many other pieces of information.
But we always have to look at the whole picture.
Absolutely, but I think when we have a number, as human beings, we are so fixated on numbers. This can translate back to the ejection fraction, where we thought that higher ejection fractions would lead to better prognosis, and that hasn't been the case. So I think because we always want to hang our hat on, this is a number that means this, I think it's taken out of context. And I think we have to say a BNP of 4,000 may very well be heart failure, and we know that patient is at increased risk. It certainly prognosticates the patient, but I think we also need to take other things into account.
And Dr. Penny, do you agree with that?
I agree with a lot of what she says. I mean, I definitely use biomarkers. You get phone calls all the time, usually from the emergency department, for patients presenting with dyspnea, oftentimes with a normal ejection fraction, the first thing they say is, this is a patient who has heart failure exacerbation, they need to be admitted, and usually the retort is, well, what was the BNP? So for patients who present to the emergency room with dyspnea, having a low BNP, less than 100, has a very, very high negative predictive value to exclude heart failure as being the reason for their acute dyspnea. BNP levels over 400 are often tightly correlated with the presence of heart failure and congestion. But where I will agree with Anu is that oftentimes in those individuals who have elevated biomarkers, have elevated levels of natriuretic peptide, and significantly elevated levels of natriuretic peptide, I will wager that you didn't need the biomarker to tell you that that patient was in decompensated heart failure. So for any non-invasive test, where it proves its salt is in the middle ground. So someone presents with dyspnea, they have an elevated biomarker, they have a BNP level of 200. Is that because they have heart failure? Is it because they're COPD? And the answer is we don't really know. So in terms of the performance characteristics of natriuretic peptides to differentiate causes of dyspnea, I find it's less helpful in the area where I need it the most, and that's where it comes back with an intermediate level. Definitely helpful for its negative predictive value for those patients who have a level less than 100, not very helpful for those patients who have levels higher than 100.
And does anyone on the panel use changes in BNP during an acute hospitalization as a way to monitor patients?
Before Jim jumps in, I do want to just remind everyone that we have a heart failure pathway here, and part of that heart failure pathway is to draw a pre-discharge BNP level. And there are several reasons why we want to draw a pre-discharge BNP. There are several ways for us to decide whether or not we've appropriately decongested a patient, but we do want to see a reduction in biomarkers, a reduction in BNP. Whether or not it's a percent reduction in BNP or an absolute reduction in BNP, we haven't yet figured it out. I will defer to Dr. Iannuzo in that regard, but we are trying to answer that question here. So there are two reasons why we draw a pre-discharge BNP. One is to make sure that patients are appropriately decongested. The second is to then correlate the pre-discharge BNP level with subsequent readmission rates and subsequent heart failure outcomes. So with that, I'll turn the rest over to Jim in terms of guiding therapy.
So even before I get to that, I just wanted to say, Donna, I agree entirely with what both speakers said about the need and the value. Let me embellish just a little bit about the use and diagnosis. I'll remind everyone that the natriuretic peptides have a class 1 level of evidence A in the guidelines for diagnosis. However, when we wrote that, we articulated it with the caveat that they are specifically useful to help reduce clinical indecision. They are not a panacea. They do not replace clinical judgment. And as Dr. Penny mentioned, often the very patient where you might need them the most, they sometimes aren't as useful. So, they come with all of the same warts that other diagnostic tests come with. I will say, however, that you're listening to two people trained in heart failure. And when I first started doing the PRIDE study, I got a much more vigorous, perhaps, pushback from clinicians about natriuretic peptides. It was much more along the lines of, what in the world are you doing this for? We don't need a blood test for heart failure. I know how to diagnose heart failure. It turns out that not every physician has the diagnostic acumen of Sean Pinney for heart failure. And so I think one needs to think in the broader context of the medical society we work in, where an emergency medicine physician who has to worry about how to do rapid sequence intubation for head trauma and pediatric infections and abdominal pain, et cetera, may not necessarily know how to read neck veins or do a Valsalva square wave to assess degree of congestion. So that's one very important point. But even putting it ahead one more step, we actually did randomized controlled trials where we looked at what does adding a natriuretic peptide to clinical flow do to not just utilization and cost, but also outcomes. We did a study up in Canada called the IMPROVE-HF study, looking at randomizing 250 patients to an NT-proBNP guided approach, diagnostic approach, versus blinding the NT-proBNP. And it was substantially cost effective, reduced the granularity of workup, much less sort of diffuse workups with CTs and PFTs and other testing, and actually improved 6-month outcomes, in particular, reducing rehospitalization. So I do think that there is value in having the test as part of the upfront understanding of one's patients. I also agree that the biggest value is the negative predictive value, as Dr. Pinney said. If you've got a low value, it really does exclude heart failure and certainly puts patients at lowest risk. Now, that's the upfront measurement. And so if someone put me up against a wall and said, do you need an NT-proBNP at admission? My answer is no, I don't really. I can do the neck veins and listen to the heart and listen for the S3. But the pre-discharge value and the change from baseline to pre-discharge is actually quite valuable for understanding where that patient is heading. And if you don't have the baseline value, you really can't assess the delta during treatment. And the guidelines just gave that in-hospital monitoring indication a Class 2A recommendation for assessing risk. And so what we're doing at the MGH is exactly what you're doing, Sean, which is measuring the pre-discharge value and then leveraging it to make decisions about whether this is a patient that we should put in the CON7 program and bring them back within a week, or home telemonitoring, which obviously is not for everyone, or home nursing, or keeping them in the hospital, and intensifying their therapy. Because right now, the goal, right or wrong, is to prevent readmissions. And so, and improve outcomes, obviously. So that's where we're largely focusing the efforts on that.
What levels are you looking at?
Yeah, so we're looking for a 30% reduction in NT-proBNP. It turns out both are important. The absolute value as well as the delta are both independently predictive. Just think about it. If you start at, say, a BNP, I'll switch my language over to BNP. If you start with a BNP of 5,000 and you go from 5,000 to 3,000, you're still worse off than somebody who starts at 1,500 and goes to 1,000, right? So you may have had a larger relative drop, but you're still higher. So we integrate both, Donna, but in general, the people who have the most robust reductions are often the ones with lower values anyway.
We have focused mostly on BNP during this discussion, but is there value in looking at some of the renal biomarkers that would indicate whether there's acute injury to the kidney?
Dan,
NGAL, KIM,
I'll give you a pass on that. He didn't look at them. So and that's okay because the data are just a mess. So there are markers. The hope is that we can identify something that we could use as almost like a renal troponin, right? Injury of the kidney. So NGAL is a siderophore, so it's an iron-binding protein that the kidney releases, in particular in the setting of renal infections, actually, because it turns out many bacteria in the kidneys are iron-loving, and so by binding up iron, it helps to defeat renal infection. It turns out that in the context of renal injury, NGAL levels may rise, but it's a very promiscuous marker. It rises for a lot of reasons, and so early enthusiasm for NGAL has really died down. KIM1, or kidney injury molecule 1, in the urine has been suggested as another potential player. It had not panned out very much. We have data in our group right now. So Nazreen Ibrahim, who's a faculty member with us, who worked with me, is writing up a paper that we're going to be sending into a suitably high-tier journal looking at KIM1 concentrations in the blood, actually, which has not really been well explored. And we found it to actually very powerfully predict acute kidney injury as well as progression of chronic kidney disease. So that may be of value. I think the bigger question, though, is what are you going to do with the result, right? And that's the thorniest issue with prognostic markers of any kind, whether it's cardiac or renal.
But don't you think that you may change your therapy?
I think I would, but the question is, are there other things that we can do that we can link the result up with to specifically address the kidney injury itself? So on the one hand, absolutely, I'd renally dose my drugs. I wouldn't put the patient in the cath lab necessarily, but those are all being reactive as opposed to being, proactive. Those are being proactive rather than being reactive to try to mitigate the renal injury. Unfortunately, ultrafiltration didn't pan out
No,
you know?
but if you found that there was no evidence of renal injury and that it was really from a reduced cardiac output, then
Yeah.
you would have a tendency to move towards inotropic support.
That's a very good point. And we did some studies where we combined multiple markers, looking at, for example, NT-proBNP and KIM-1, showing that patients with elevated both, those are people with cardiorenal syndrome who you should continue diuresing, right? You know, it indicates that the injury to the kidney is more likely to be due to congestion. Now, of course, you know, physical exam would tell you that, right? But again, I'm blown away by how commonly our patients with cardiorenal syndrome come up from the emergency department or in transfer or wherever with a bag of saline running wide open because the creatinine's high, right? And so I do think there's potential value in that context. I'm waiting for, though, in our space, I'm waiting for a therapy that actually addresses cardiorenal syndrome with something other than drugs, you know? There's, Abiomed has a device that they're focusing on now that may be an intrarenal vein impella, essentially. That afterload reduces the renal veins, you know, to reduce renal plethora. Might be interesting, but just think about how many patients we'd have to put those devices into, you know? So it'll be interesting to see how that plays out.
Let's shift to the management of chronic heart failure. And Dan, Mr. Jones comes to see you. He's 75, he's obese, his BMI is like 34, he's hypertensive, he's diabetic, his EF is 35%. He's just coming back for a follow-up. He's on Coreg 12.5 twice a day, lisinopril 10, aldactone 25. He feels really good. You know, he can walk 2 to 3 blocks. You know, he has a good quality of life. He's a happy man. And on physical exam, his blood pressure is 120/80, his pulse is 68, his physical exam is unremarkable, his BMP is 100. Are you happy too?
I think so.
What?
I think so. This is a gentleman, the only thing that sounds like is not going well is that his EF still remains down. He's on good neurohormonal antagonism. Perhaps there could be some room on some more in terms of blood pressure and things like that. His BNP level, although he's obese and that can falsely decrease your level somewhat, it is within goal range. Not that that's would be something I would.
So you'll pat him on the back and shake his hand and say, "See you in 3 months."
I mean, you're saying he has no symptoms? He's
it's 2 to 3 block. 2 to 3 block.
So he still has symptoms then, I think if there's a role intensifying therapy, then I would continue to intensify therapy. I mean, you're still at below goal doses of your Coreg. You're at 12.5 BID. There's still room to go up on all those medications, and if his blood pressure and stuff still tolerated, there's roles in adding and things like
good
that.
answer. Good answer. So his heart rate was 68. He got blood pressure. He's not on goal-directed doses. You go up. You know, he attempted to say, like, let him alone because he's happy and everybody's happy, but you shouldn't. You should up-titrate.
So this is controversies, right? So I agree with you, but I'm going to throw this out there, which is if you had a way of knowing that you did not have to intensify therapy, would you feel comfortable not intensifying therapy? In other words, if you had a non-invasive test that said, this guy doesn't need to have his Coreg increased to 25 twice a day, would you feel comfortable non-intensifying? This is a highly controversial discussion in the heart failure space.
You know, quite frankly, my practice has always been to try to up-titrate, and particularly when someone's not fully beta blocked. You know, like I will push them. And when I have, a blood pressure that I can work with, I will, convince them that, you may feel well, but you could feel better. And I want to be proactive.
I like that answer, and I'm the same. I would increase as well, but I took a beta blocker for the first time in my life not long ago. One dose. I had, it's awful. It's awful. And I know that's different in heart failure.
It doesn't matter. You know, it depends on who you are. You don't need a beta blocker.
Well,
I've taken a beta blocker.
My EF is normal. But the point is that there are potential upsides. You know, there are potential upsides to avoiding overtherapy. And I think that we have the heart failure, we have painted ourselves in a corner in the way we designed our trials to intensify everything to the highest doses. And there's this belief that higher doses are better, and that's largely true. But it also turns out that patients that can get to higher doses are more treatment responsive, whereas in the real world, we don't deal with such patients. You know, the real world carvedilol dose is half that of clinical trials typically. So the bigger question that I ask now is someone that, you know, recognizes that it's important to maximize doses to be guideline compliant, because as we know from clinical trials, that's the best way to get a best outcome. If we had a non-invasive tool to help to make decisions, not just to intensify, but to know when we've reached an adequate level of treatment, which doesn't mean you would stay there. Say this biomarker then said, you know what, this person's worsening, you need to intensify now. That is, in some ways, the way we manage diabetes. It's the way we manage hyperlipidemia to some extent. So, you know, I think that having that biological barometer for deciding on treatment intensity is something we've lacked in heart failure. And as I said, it's a controversial topic. Drives heart failure people crazy, you know, to think that we might not go for target doses. So I'm not saying that that's what we should do, but I actually feel as a clinician that it's not an unreasonable goal to think about.
On a different topic, myocarditis. What is the biomarker that you use to monitor for inflammation? The expert.
The expert. So myocarditis, the classic sine qua non biomarker signature of myocarditis is a rise in troponin that does not come down. So a patient comes in with an acute cardiovascular presentation, could look just like a myocardial infarction, but the troponins just rise and they hover. And you'll see that with highly sensitive troponins even more. You can have, you know, as we say in Boston, you know, wicked high levels of troponin. For all the world, it looks like a huge myocardial infarction, and yet normal coronaries. So Bill Deck in our division published a very nice series years ago now, but still very highly cited, about how myocarditis can mimic myocardial infarction. And that's the tip-off, is that high and non-changing concentration. But the other biomarker that I use is cardiac MRI, actually. You know.
Right, but that's not a biomarker, really.
Well, it's an imaging biomarker.
It's not a, because the question I was going to ask you is what biomarker could correlate with the changes that Gina will see on her MRI?
Well, you know, I don't know if those correlative studies have ever really been done.
Actually,
yeah.
published today.
Oh, okay. Well, there you go. Just today, hot off the presses.
Actually, in JACC, and it's coming out next week. It's available on the internet right now. It looked at Dr. Blumke from the NIH, now at University of Wisconsin, took about 1,300 patients from the MESA study, looked at NT-proBNP and cardiac MRI, and looking at fibrosis using T1 mapping pre and post contrast, and the extracellular volume, and noted that there was a direct correlation with the rise in NT-proBNP and cardiac fibrosis. So.
Yeah, I'm embarrassed to admit I handled that paper and didn't remember it. So. but if I can, you know, but if I can, I think this is important because it really moves away from myocarditis to I think really where the future can be for markers, which is not even primary prevention, but almost primordial prevention, which is taking these very sensitive markers and measuring them in us, in people who do not yet have, you know, active manifested cardiovascular disease, with the hope that we can detect a signal even earlier and potentially intervene. There are now 2 trials looking at, in one population, patients over age 18 with one risk factor. So me, I've got hypertension. I would have qualified for this study. It's called STOP-HF. And there's another study that was a pilot study looking at patients with type 2 diabetes, a group of patients with expanded cardiac fibrosis on MRI, if you looked at them, and a high pretest risk for development of heart failure. And in that study, the Pontiac study, also published in JACC, randomized patients with an elevated NT-proBNP with diabetes to intensified therapy versus usual care. And you know what usual care means, right? That's, see you in a year, bye, hope you do well. And in STOP-HF, that was a study done in Northern Ireland, 39 centers, one risk factor or more over age 18. If your BNP was over 50, 50, you were randomized to intensified therapy versus usual care. And in both trials, the identification of at-risk subjects without prevalent heart failure at baseline and intensifying their therapy prevented onset. We've published now in JACC Heart Failure a number of papers looking at what does an elevated BNP mean in somebody without heart failure. And I'm using air quotes because, the first is what the question that clinicians ask, BNP is high, but they look fine. Well, we now have a good handle from studies that this identifies remodeling on MRI. Dr. Blomke's study in JACC, I'd encourage you to read it. It suggests that it's associated with fibrosis in the myocardium. And this has a therapy that you can potentially reach for. It's RAS inhibition. It's, addressing cardiac risk factors. Maybe it's SGLT2 inhibitors in patients with diabetes. So yeah, again, same. So, the guidelines actually, once again, and I think, Dan, when you think about a write-up, doing an up-to-date summary of what the guidelines have articulated for markers, in particular the natriuretic peptides, would be highly publishable to summarize the knowledge base that underlies each of the steps that they've recommended. The guidelines have given a 2A for this primordial prevention, which is taking someone who's apparently well with a risk factor and measuring a BNP or NT-proBNP, and it's undoubtedly going to come to the highly sensitive troponins. And we showed with ST2 in the Framingham the same thing. It predicts heart failure onset. So eventually we may be shifting our focus from, the patients that Sean Pinney sees to the patients that are seen in primary care, maybe.
One group that I agonize over and I don't really know what to do about, or the patients who have family members that have developed severe cardiomyopathies and they get genetic testing and they have the same genetic defect. And I try to get them to take low-dose beta blockers or ACE, but frequently they don't want to do that. What is my trigger? Is there a biomarker that can trigger, me starting therapy? Sean.
Yeah, Sean, why don't you take it?
I mean, this is the challenge that Donna articulated, genotype positive, phenotype negative, and for reasons that we don't fully understand, or certainly I don't understand, some of them remain that way. They remain that way indefinitely, where they don't, even though they have the genotype, they don't express the phenotype. And so when you identify someone like that, maybe they're younger in age, maybe they're still a child, is there an opportunity to intervene? And the truth is, I certainly don't know that has been identified yet. When is the proper time?
Is Dr. Seidman doing any kind of studies looking at, MRI fibrosis or biomarkers?
Yeah, as Sean said, it's early on, but there are data showing that both NT-proBNP, well, actually not both, there are multiple markers, may be sensitive early in disease. So with patients with Duchenne's muscular dystrophy, for example, concentrations of ST2 actually identify patients at risk for progression. NT-proBNP and highly sensitive troponin as well. So I keep coming back to those three because although every single marker that Dan mentioned I've measured at one time or another in my career, there are very few that I think have a viable clinical role. Most of them are of biological interest and may ultimately be useful for drug development, and clinical trial work, but for clinical utilization, the three that I come back to frequently are highly sensitive troponin, NT-proBNP or BNP, and ST2 as well. In patients with family histories of cardiomyopathy that I follow in the office, genotype positive, phenotype negative, I do measure NT-proBNP as well as ST2, actually. And I have found that ST2 is more sensitive, actually, for the onset of cardiovascular dysfunction. And I use them as a gatekeeper before I go to imaging. So if they're negative, I don't go to cardiac MRI. Save the money, see the patient once yearly. If they start to show signals of abnormality, then I tend to reach for imaging.
You know what, and one last question, because Dr. Ani was so nice, he sat up here the whole time. Is there any biomarker that you can recommend for him to know whether his LVAD-supported patients have recovered?
So we've actually looked at unloading in patients with LVAD treatment. Tariq Ahmad, who was at Duke and now at Yale, has done some really, really nice work looking at changes in biomarkers after pump implantation. Part of the problem, of course, is if you take a heart and core out the apex and then jam a fire hose into the apex of the heart, it tends to make the biomarkers a little abnormal for a while. So to some extent, the signatures of biomarkers after initial implantation, there's so much noise, it's next to impossible to interpret them. That said, the convalescent concentrations, again, of NT-proBNP, ST2, and GDF-15 in Tariq's study, all prognosticated improvement in LV function. The real billion-dollar question is, can you use them to decannulate patients? And I don't know of any data that suggests that that would be possible.
You know, I think part of the problem, though, is we're looking at the wrong biomarkers, and you're looking for markers that can solve all the problems. I think part of what Anu was hinting at is that those of us on the treatment side of medicine, our biomarkers and our needs are different from those on the diagnostic side of medicine. And you're taking tests like the BNP that are highly sensitive with very good negative predictive value, which really shouldn't be used on the treatment side, but should be used on the diagnostic side. And you're applying them to treatment scenarios. So for those of us who are treating disease, we're looking to stratify patients based on how they will benefit from our therapies. And a very sensitive test like that won't work because the utility of a test depends on the circumstances in which it's used. Unless you have a high, on the treatment side, unless we have a pretest high predictive value, then the test is going to be of very little utility. And one thing that you didn't mention was biomarkers for fibrosis. And that's really what we need from the treatment side. Like I sat down with Gina for 15 minutes earlier this evening, trying to figure out whether a patient had a lot of fibrosis, such that whether they would respond to conventional surgical treatments. And that's what we need on the treatment side. How do we see a patient with heart failure and know that if we fix their aortic valve or mitral valve or coronary disease, that they will get better? And unfortunately, these tests that you have that you've been talking about don't really apply to the treatment side. But what we need more are, better markers like procollagen peptides that will correlate with what we see in the clinic. And that's the problem I have as a clinician, in that these markers don't seem to help the treatment. But for the doctor in the emergency room, they certainly help in the diagnosis. But for most of us, the diagnosis is made by the time the patient gets to us.
Yeah, so a number of really important points. I think one of the most important, very elegantly stated, is how pretest probability affects the post-test interpretation of any test, right? And so that's a very important observation. I would say that one redirect for one thing you said, so part of the problem, of course, with any question, any clinical study that is done is what data are available to investigate the question. There are no randomized trials of aortic valve replacement based on a pre-implantation biomarker concentration, right? If we had that, that would really be nice. There are data from the TAVR experience, actually, looking at markers pre-implantation to predict post-implantation outcomes. You're right on target about fibrosis, and it is largely markers of myocardial injury, troponin, as well as ST2. So Brian Lindman, who's now at Vanderbilt, One of the Vanderbilt has become sort of like the Death Star with the tractor beam pulling good academic physicians in. Brian just went from WashU to Vanderbilt, and Brian's done some remarkably elegant work looking at pre-TAVR markers to predict post-TAVR outcomes. And he has a sort of a model that incorporates multiple markers with clinical variables to really answer that big question of, should I implant a device in this patient, because as I'm sure is the case here at Mass General, our TAVR population is, well, a little bit comorbid. They're kind of older. And so there are times when we put a TAVR in and the outcome is not what we wanted in terms of recovery. And so I do envision those retrospective data will hopefully inform a prospective study someday. But again, I'm not sure we can change our practice on the basis of retrospective data. We really do need a prospective study, and that's where we're lacking.
I'd like to open it up to the members of the audience if they have any questions. Yes, sir.
So when you say a BNP of 100, it seems to me that you have wiggle room, that you kind of take your time and push your therapy and thinking of the long haul. But what if someone comes in who's reasonably okay and not congested and his BNP is 400? So then do you have a sense of urgency when you have all these pills that you can use? Do you think in terms of diuretics more than beta blockers and Tresto? Do you follow up faster? Do you drive the therapy faster?
So the first question is always, why was it tested, number one? And, we sometimes in our office, just for complete disclosure, we measure an NT-proBNP in all of our heart failure patients at each of their visits. We just do. Granted, we're a natriuretic peptide hospital. We do a lot of work in this space. So one question is, where was the marker at previous measure? If you have another measurement and there's been a change, that's an important observation. In addition, you need to think about why is it elevated. So here's a classic scenario that we're seeing more and more, and I don't know if it's your impression, but I really believe there's much more amyloid in the population than had been recognized. And amyloidosis is a diagnosis that causes the unexpectedly elevated BNP. And this has to do with the fact that the diagnosis, less about congestion, more to do with toxicity of the transthyretin or whatever mechanism of amyloid we're talking, is directly injurious to the cardiac muscle, causing release of markers. So when you see the surprisingly high BNP in someone who seems to be uncongested, think about things like that, the non-congestion mediated drive of an elevated natriuretic peptide. But all of that said, a patient with a BNP of 400 is at high risk, and so one has to at least respect the fact that there's really rarely a false positive for these tests. And so one has to try to understand, where the patient has been in terms of their values and where they're going. In the absence of obvious congestion, I think it's hazardous to diurese a patient. I think it's really more, again, a question of trying to understand why it's elevated and targeting that elevation. So if it's aortic stenosis, it's replace the aortic valve. If it's mitral regurgitation, it's either clipping or repairing the mitral valve. If it's atrial fibrillation, it's restoration of sinus rhythm if possible. And so the idea of individualizing care is the goal here.
And you have to remember that if the patient is on Entresto, you're not going to look at the BNP. You have to look at the NT-proBNP. Okay.
Yeah, very important. Thank you for bringing that up. I remind everyone that neprilysin degrades BNP, and so if you inhibit neprilysin, one's BNP rises. And people have taken a very blasé attitude about the results of Paradigm. People say, but it only went up by 50 picograms. That's no big deal. I can read through that. Absolutely incorrect. Again, just today I got more data from a cohort study that we did where we measured multiple BNP assays, because it's not even clear that every BNP assay is affected the same way, because neprilysin assaults the BNP ring in multiple places. And so the different BNP assays are based on antibodies that bind in different places. And so we measured 4 different BNP assays as well as ANP in a bunch of patients treated with Entresto. And what we found was, number one, every assay is affected differently. So there's no universal, they go up by 30% kind of thing, number one. Number two, this makes some intuitive sense. The more BNP you have before you treat a patient with Entresto, the more rise you see after you treat them. So makes sense. If the drug blocks its breakdown, if you start with a lot, you're going to have a lot afterwards. So patients that have very low BNP concentrations before you start Entresto, they don't rise very much. So there's no standard amount of rise to expect. So when people say, it's just 50 picograms, that's absolutely not the case. We have some patients that started with a BNP of around 1,500 and went up to 10,000 after starting Entresto. And you're not going to be able to interpret stability in that setting using the biomarker, at least. With NT-proBNP, that's not affected, though.
Yes.
With diastolic dysfunction, have any of these markers given us greater ability to untie that Gordian knot?
It is really a Gordian knot, I agree. So I like the way you phrase the question, because certainly heart failure with preserved ejection fraction has elements of diastolic dysfunction, but you know what, so does reduced EF heart failure. So the question that many of us are asking is, short of echo or MRI, to look at diastolic function, are there circulating markers that can be used? And the answer is absolutely yes. Multiple biomarkers have been looked at in this context. Many, if not most, are tangentially related to diastolic function. The natriuretic peptides, for example, are, but they're also related to systolic function, pulmonary pressures, so they're not specific at all for diastolic function. We just found a marker, so Pearl Gandhi, who was a fellow here and who came and worked with me for 2 years, when she was working with us, we were looking at a set of markers identified in a proteomics search for markers of ventricular remodeling and fibrosis. And among the markers that we looked at was one called insulin-like growth factor binding protein 7. It's kind of a mouthful, but if you look at IGF-BP7 agnostic to the heart, what you find in the literature is that it's strongly associated with metabolic abnormalities, including diabetes. It's associated with obesity, and it's actually associated, what its biological role is, it's a lousy insulin binder. So it binds insulin like growth factor, somatostatin, but it's not very good at doing that. What it really is in the body to do, actually, is it's a cell cycle arrest hormone. So when tissues are injured, concentrations of IGF-BP7 rise to stop cellular division, with the idea that it reduces risk for malignant transformation and other things like that. So with that in mind, if you describe the phenotype of elevated IGF binding protein 7, it's the obese diabetic patient with diastolic abnormalities, it turns out. So we found that this marker was, when you looked at cardiovascular structure and function, strongly associated with diastolic dysfunction. It's the best predictor of left atrial volume in heart failure with preserved EF, better than NT-proBNP for predicting left atrial size. And it is as prognostic for adverse outcome as NT-proBNP and HFpEF. So our hypothesis is that this is a biomarker of tissue senescence and aging, and that's actually exactly where Marv Konstam and others are focusing their interest now in preserved EF heart failure, as a paradigm, if you will, for advanced tissue aging and abnormalities of tissue senescence in heart failure. And so we'll see. It's interesting. We have some data looking at the effects of Entresto, actually, and it lowers concentrations of IGF-BP7 in parallel with the reductions in left atrial volume that are seen in the Paramount study. So looks pretty promising, actually.
So thank you, Dr. Iannuzo.
Thank you.
You may be a Red Sox fan, but you're welcome back to New York.
Well, I'm glad to hear I can come home, all right?